Okay, everybody, we're going to get started. Thank you guys for joining us. It's busy in the hospital as usual, but thank you for taking the time out of your day to come join us. Today, we have a very special guest. We have Dr. Satish Nagula, who is part of our division of Gastroenterology. You guys probably work with him or know his name. He's one of our advanced endoscopists, and so obviously for a lot of our patients in it as an endoscopic center of excellence. So we're very happy here to have Dr. Nagula here today to give us some insights into some of the things they're doing. Thank you very much for joining us.
Awesome. All right. Well, thank you guys for having me. I certainly have seen your names on all of our patients' charts, so thank you for all the care you provide for our patients. I wanted to, I really appreciate the invite. Wanted to use the chance to just sort of go over some of the various things we do for our patients, just so you have a framework of, the kinds of things we can offer, the kinds of things to expect, and just a little bit of background about some of the disease states and so on. I really want to keep this sort of laid back. I have a ton of slides, a bunch of videos, and we'll just kind of go through things. So, all right. I'm going to go through 4 main topics, which I think cover a lot of what we see on the inpatient advanced endosurgs. And so that's malignant GI tract obstruction, management of leaks and fistulas, necrotizing pancreatitis, and then the drainage of abscesses and gallbladders. And a lot of this stuff this talk would have been very different 3 years ago. It's just that we've just had such an expansion of technology and techniques that we really are able to do so much more than ever in the past. So probably the oldest topic on the list is malignant GI tract obstruction. This is actually a New England Journal article from 2001, and the basics of it haven't really changed all that much. And the idea is patients who've got luminal obstruction of the esophagus, of the duodenum, and of the colon, all of these can be readily treated by endoluminal stent placement. It was sort of one of my first loves in the GI endoscopy world, and it's still some of my most favorite procedures to do. All of this is based on the technology of self-expanding metal stents. These are very different from sort of cardiac stents. The idea behind these is these stents, which are made of an alloy mesh, they get elongated and stretched out onto these long catheters here. And you can see here is a catheter. As the stent's being deployed, you see it opens up, but it tapers into this catheter. The thin catheter allows us to put it through scopes and advance the stent in place. And then it expands open like a spring. And it's that tension up against a tumor, for example, that holds the stent in place. It actually expands over 24 hours. So as it expands open, it pushes the tumor aside, and then it restores patency to the lumen. They come in all sorts of different shapes, sizes. There are numerous different companies and brands and everyone trying to sort of corner the market on these. So to go through each of the main sites, so when we think about esophageal stents, the biggest reason we use them is for malignant dysphagia. And we'll see this in patients largely with esophageal cancer. Well, if you look at dilation, it doesn't work that well. We can go in with the scope and stretch it with the balloon, but it's a tumor. So you're going to push the tumor aside, and then once you deflate that balloon about, they say a week here, but even a few hours later, that tumor comes back in, and it doesn't really help the patient for any durable period. Our APC and photodynamic therapy are methods of cautery, and the idea is maybe you can necrose off or burn away some of the inside parts of the tumor. You may get a little bit of more duration out of it, but it's really just not that durable. When you place a stent, you ideally can maybe get up to 4, 5, 6 months out of the stent. And then chemoradiation is going to be probably the most durable, and that'll last the longest because you're actually treating the problem. So we tend to approach patients with the multimodality approach. On patients who come in with a new diagnosis, many people come to the ER with sort of progressive dysphagia. So even before the diagnosis is made, we'll go in, we'll take some biopsies, and we'll place a stent. Ideally, we like to have pathology first. Once you put a stent in there, you can't really biopsy again. So then we often use it as a bridge towards their treatment. And so we put the stent in, they can go on to get chemoradiation, which can take a few weeks to start to work on their dysphagia. And then some patients have finished treatment and now have recurrent disease. And so it's, instead of being a bridge sort of therapy, it's sort of more of a permanent issue. Peg tubes are great. I still love peg tubes, and I think for some patients, pegs are the right choice. There are plenty of patients who have horrible dysphagia issues, but really have no desire to eat. So to put a stent in them doesn't really help them at all if they're nutritionally just not going to cut it anyway. And so peg tubes, many times there's an interest in we can place a stent, we can place a stent. And I'm like, well, yeah, but the patient still has to eat. So I always try to make sure with our fellows that the patient is someone that's going to eat, and that's really what they want. As we all sit here and eat lunch, eating is such a big part of our patients' lives, and so there's even if they may not get enough calories, there's a social construct to it. It's an opportunity for them to feel normal. So the palliative component to this, even in patients who are kind of late stage, I think is very important. Here's an esophagram in a patient who's got like a squamous carcinoma of the esophagus. Normal upper esophagus here, you can see a narrowed irregular lumen right in the middle, and then a normal distal esophagus. And then after the stent is placed, you can see where the arrows are now that lumen is wide open, right? It's sort of this long, this wide sort of bridge here, and now contrast flows in pretty easily. The issue with stents is, of all the stents that we place, these are probably the most frustrating because they have a lot of potential complications. So most of the stents, well, historically the stents we used to use, there were that mesh that I described. And what happened is tumor would grow into that mesh. And the nice part about that is it held the stent in place. Recently, the market has switched, and now they've put silicone coatings around that mesh. Now tumor doesn't grow in. Since the tumor doesn't grow in, peristalsis tends to push these stents. So these stents do slip and slide a lot. The uncovered stents had a lot of ingrowth, so after a few months, the tumor would grow in, and you'd have to re-stent them. The covered stents don't have as much of that problem. Because of that ingrowth problem, the uncovered stents, they had recurrent symptoms. You had to stent them again, whereas the covered stents wasn't as much of an issue. The other big things we see with these stents is that almost all patients have a combination of nausea, acid reflux, and vomiting. You're basically going down to the lower esophageal sphincter, which has been closed for some duration due to the tumor. And once you open that up, the stomach just goes crazy because now it can contract and stuff can flow in every direction. So the first 2 days after stent placement are usually not fun. There is a small percentage of outpatients who get admitted. And the patients who are here, we fortunately can at least give them pain medications. And if we can get them through the first couple of days, they generally do okay. But, so all of these patients, from my standpoint, are put on high-dose acid suppression because, again, now that that's open, now the stomach, the path of least resistance is actually up and out, right? Not the pylorus. And so they all are very nauseous. They all have horrible reflux. So all these patients end up with high-dose PPIs. It's not fun at all. I see people going, "Now this sounds terrible." Yeah, it is actually pretty terrible. But malignant dysphagia is also horrible because these patients, even after you stent them and they do okay, they are afraid to eat. Choking once is a petrifying experience. And knowing you've choked a lot over the weeks and months before, I've had so many patients who just refuse to eat because they're just scared. Even though that everything is wide open, the esophagram is good, everything is good, they're just like, "Oh, I'm just going to stick to liquids." So, but the nice part is after a couple of days, most patients adapt pretty well. And so after that adaptation period, they may have a little discomfort, for the most part, do pretty okay. Of all the things I talk about today, this is the one, I think, procedure we do that I don't really love anymore because I think the side effects of it are not great. But patients do end up getting through the stent period. They are able to eat. They do pretty well. It can go on to chemo and even surgery. So it is something that does work. Duodenal stents, so gastric outlet obstruction. So there's sort of, the two main causes of gastric outlet obstruction. So that includes the pylorus and the duodenum. And so we'll see patients with pancreatic cancer or duodenal cancer, and that'll grow right into the duodenum and cause obstruction, or even gastric cancer, and that'll actually, you'll have a mass at the level of the pylorus. These patients tend to have pretty tremendous, by the time they come to the hospital, they generally are regurgitating undigested food. And when you get a CAT scan, their stomachs are basically in their pelvis. I mean, the entire abdomen on a coronal view is impressive. Many times people see a big stomach, they're like, that's a big stomach. I'm like, I always tell our fourth year fellow on week one, like, that's not a big stomach, just wait. And then all these patients, the stomach is actually below the pelvic rim because the stomach has been obstructed, but this is not an acute process. This is when you have malignant obstruction of the duodenum or the pylorus, that lumen has been closing for weeks. And so in response, the stomach has been stretching and stretching and stretching. And so most patients Because, I mean, someone comes with pancreatic cancer with duodenal obstruction, you know it's been there for quite a while. But you talk to them and they're like, I just started vomiting yesterday. Well, that's because their stomach's been stretching all this time. And so most of them will say, I've had bad acid reflux for the last month and, you know, never had it before and nothing is working. And that's because as the stomach's stretching, the stomach is full, there's a lot of stuff refluxing. It doesn't respond to PPIs because it's not acid, it's bile, it's food, it's everything. So all these patients, their esophagus actually looks pretty raw because the stomach has been stretching so much. But that's pretty much true for every single one of these patients. So there's 3 ways to sort of palliate gastric outlet obstruction. In some of the later stage patients, we'll do a venting gastrostomy. It's basically a big peg tube. It is a big peg tube. But instead of using it to feed, you use it to vent or to drain. So we'll see this in some of our more terminal patients, metastatic ovarian cancer, you know, refractory pancreas cancer. They just want to stop vomiting, right? And that's a horribly miserable state of life. And so by putting in a peg tube, you just leave it open to a bag. And instead of having an NG tube in, now it's open to gravity. Anytime the stomach is full, it just drains out into the bag. Again, it's a very terminal thing to do, but it provides a lot of relief, and it's sort of your peri-hospice type of thing that we do. It's sort of a grim procedure when you think about it at face value, but again, it's a huge quality of life gain for these terminal patients. It gets them out of the hospital, which is nice. Duodenal stents is one option, and the other classical option is a gastrojejunostomy, which is a surgical bypass where they actually take the jejunum and bring it right up to the back wall of the stomach. And so in certain patients, that is actually something that is still done. So here's a patient, they have pancreas cancer. This is the duodenum, and the lumen is actually quite narrowed. You can sort of see some infiltration by tumor up here. And then under fluoroscopy, what we do is we advance a wire. And so here's my scope in the stomach. And then here's a wire going all the way across the duodenum. So this is sort of D2, D3, and up to the ligament of Treitz. And this is the stent catheter here. And that's our stent catheter. Then you can now see the stent that's open. So you see a mesh here. There's an open mesh here. It gets very tight in the middle where the obstruction is. And the mesh is opening in here. Again, in the duodenum, you don't need a huge lumen. This expands over 24 hours. So again, we talked about there was that sort of stretching effect. In the duodenum, if your stomach is functional, peristalsis would have ground down the food to liquid anyway. So you don't need a massive opening like you do in the esophagus. In the duodenum, you need some degree of patency, and then you hope that the stomach peristalsis will grind things down. And then that's the stent open again. You can see there's a metal mesh here. Gastric outlet obstruction, first of all, generally speaking, is if you develop gastric outlet obstruction from your cancer, it's a fairly poor sign. You know, more than half of these patients are dead within 6 months. And so if you think about it, if you have enough to obstruct your pylorus or your duodenum from pancreas cancer, duodenal cancer, the long-term outlook is pretty poor. This is a study looking at comparing the effect of like surgery and stent on nausea and vomiting. And, you know, nausea and vomiting score is high in the beginning. Within 3 months, much improved. Eating restrictions also much improved in these patients because surgery, that gastrojejunostomy and the stent both work very, very well. If you were to compare the two, it's a large series. Clinical success is fairly comparable, maybe stents a little bit more. You have to think about these are, again, cancer patients, so they're certainly sicker than many others. In terms of complications, about the same number in both groups, but in the stent group, in terms of a late complication, the stents rarely migrate, but sometimes get occluded with tumor ingrowth. Again, you're putting in a stent in there, a tumor can grow in there. In the surgical group, they often have anastomotic problems, you know, where it leaks or the anastomosis just doesn't open up very well. Again, these are sicker patients, so they may not necessarily do very well with surgery. There's a lot of minor complications, mostly related to surgery. Hospital stay after a stent, 7 days is probably on the long side, but after surgery, they're having surgery after all. The biggest issue we see with these patients is, as we talked about, that the stomach is stretched and stretched and stretched and stretched for weeks. So once you've opened up the obstruction, the stomach is kind of atonic, right? Because it really hasn't had the ability to peristalsis in quite a while. So what we'll often do is, again, high-dose PPIs, get rid of at least You make a couple liters of stomach acid a day. So just by putting them on PPIs, you've made more room. And then also we give them some Reglan usually for a couple of days just to get some motility back in the picture. These patients might remain symptomatic for a few days afterwards. But the stents work very well. This is a very satisfying procedure to do. Patients kind of go back to feeling pretty good after doing these procedures and generally don't really have any like side effects from these stents. So I sort of consider that a pretty good win. Colonic obstruction, oddly enough, is probably like one of my most favorite stents, although it can seem gross at the outset. Here's a patient that came in basically with abdominal distension. And you can see here, this is the splenic flexure, and there's an apple core lesion right there. This is the proximal, the transverse colon, and it's very dilated and full of stool. So this is a new diagnosis of an obstructing cancer, presumably colon cancer. So the surgeons called us to go ahead and place a stent. And so what we did is we go down and you can see the tumor there. And then again, the similar catheter, and here is the stent that's nice and open now. Here's an animation of what stent placement looks like, and this is true for any of these. So in this animation, there is an obstructing tumor at the rectosigmoid. There's a wire that goes across, and then we put a stent catheter over that wire under X-ray guidance. And then as we peel back the catheter, the stent opens up, and this is a good image of how the stent sort of pushes things aside and works very well. So here is a patient that had a colon obstruction from a mass. And then this is the deployment part. So here's the catheter here. And what you sort of see here, as we're deploying, in a second here, the whole screen blacks out because the stent is open and stool and stuff starts rushing out immediately. So you get this whole brownout, if you will. And then the staff hates this. But then we can tip in, and you can now see there's a lumen that's here now that wasn't there before. You can see the mesh pushing it open. And as we suction, you can already see like stool and stuff coming out. So the staff prepared the bed accordingly. All these patients are intubated, and as they're getting extubated, they all cough. And when they cough, they just crap the bed. And patients universally, like that night, just can't stop going because they're just emptying out this huge distended colon. But by the next day, they feel unbelievably better. It is a very satisfying thing to do. Operating on patients who've got a dilated colon is kind of bad business, and it's a risky thing to do. The mortality is very high. Many of them end up with ostomies, and I'll show you that in a minute. But placing a stent, you just eliminated the need for that emergency surgery. So surgeons call us when patients like this come in for the most part. At least the surgeons that I trust. There are some surgeons that I don't trust, and they don't call us because the surgeons themselves know it's an easier operation now. Before, they might do 2 operations, an ileostomy, a colostomy, and then come back for a resection. Now they're like, this is so much better for the patient. 1 surgery will be done. Very successful, 90-some%. Rarely do people die. Perforation rate in every series. This is an older series from 02. They've been series ever since then. That perf rate's still 4 or 5%. The reason is the colon has been dilated and stretched, so that colon wall is kind of thin. When we do these procedures, we don't use any air. It's all underwater. We've changed our techniques over the years. But at the end of the day, this is a thin, somewhat tenuous colon. And so these patients who do perforate, they'll perforate, you'll know soon after they wake up. They go to the OR. Well, if we didn't do this, they all go to the OR. So it's a tiny percentage. I don't even know if our perf rate here at Mount Sinai is even this high. It happens. It is pretty rare. So some years ago, so initially these stents were designed for patients who had metastatic cancer. They were never going to see the OR. Surgeons were like, great, we don't want to operate on metastatic patients anyway. They're not going to do well. But then the question came, well, what if you stented them up front, like the patient I just showed you already? And there have been 4 randomized trials, and the layout was this. Patients would get admitted with a colonic obstruction. They'd go for an emergent stent placement, usually within 12 hours. And then the key here, and what makes the surgery safe, is that after about a week, you can prep them. Once you prep them, the colon is no longer distended. Once the colon is no longer distended, you can anastomose much more safely. A distended colon, the anastomosis doesn't hold. It tends to leak. It's a little ischemic at the edges, and you can't take a big dilated colon and connect it to a collapsed rectum. There's a size mismatch. And so So surgeons generally will never like to do a primary anastomosis. The other group here went to emergency open surgery. They went to the OR and they basically did either a colostomy or subtotal colectomy or something like that. In this study, the stent group, 80% had successful decompression and 2/3 went on to a successful single-stage surgery. The rest of those ended up having like a temporary colostomy or ileostomy. In the emergent open group, 2/3 of them got a colostomy from in this group, and then about 1/4 of them ended up with a permanent ostomy. And only 38%, 9 of them had a successful single-stage operation. So you go from 67% in the stent group to only 38%. Comparison, the stent group, lower blood loss compared to open surgery, which kind of makes sense. Anastomotic leaks, 17% in the open group. Wound infections, higher in the open group. Again, remember, this is an open surgery. They were all very distended. Permanent stoma, 25% in the open group versus 0 in the stent group. And single stage, 67% versus 37%. All 4 other trials have actually shown the exact same results. The last one was done, I think, in 2017 or so. And so there's no question that, and then they've even looked at oncologic outcomes. They try to slice it every other way possible. And colon stents are just a big win. And all of the surgeons that I think are just really skilled and high caliber, they all just call us directly because it makes their surgery much safer, length of stay is shorter. Even in between the stent and the surgery, they can go home. You know, once they've decompressed, they can even go home for a week or two for whatever the reason. This is a meta-analysis of all those trials that we talked about. Again, much lower permanent stoma rate, higher primary anastomosis, lower leak rates, and lower wound infection rates. Some people have always asked, well, can you place a stent in the proximal colon? And we can. It's a little bit trickier, but we definitely do this pretty regularly. Can you do it in benign strictures? So the other strictures that we see are people with diverticular strictures or ischemic strictures. These stents were intended for malignant strictures. We don't really know what those stents do long-term in benign strictures. So you can do them, but if I get asked to do them, I say, well, you got to take them to the OR soon. This can't be a permanent therapy because I know the tumor is going to hold a stent long-term. I don't know what like a diverticular stricture will do. They could perforate, they could ulcerate. And so as long as we work with the surgeons and sort of say, yeah, we'll get them to the OR, it works out fine. Extracolonic cancers. So we see plenty of patients with like gastric cancer and colon obstruction, ovarian cancer, colon obstruction. It's more difficult to do it, but it works. So these are always options for patients. So in 2019, patients come in with colonic obstruction. Any evidence of perforation like acidosis or sepsis, they're going to go to the OR. They've got a perforation. We have no business being there. If they otherwise are clinically okay, they get emergent colon stent placement. Here's the thing, that cancer has been there for weeks and months. You don't need to come in the middle of the night and do this. This generally, we try to do them same day if we find out early enough, or otherwise if we find out in the evening, we just do it the next day because they're not going to perforate immediately. If we can't get the stent in, they go for surgery. If we do get a stent in, if it's benign or resectable cancer, then they go on for a single stage operation. If after workup they found to have metastatic disease or some other comorbid conditions, then they go on for further evaluation. The nice part is the stents can stay for a real duration of time, so it's not a problem there. So leaving GI tract obstruction, the next group of things that I think we see on the inpatient side are leaks and fistulas. So, you know, with leaks and fistulas, if you think of patients who've either had surgery and they have an anastomosis that's leaked, or if they had a GI procedure and had a perforation, all of these things are some kind of, you know, a hole in one of the GI lumens. And the historical approach has been they go to surgery. And sometimes this is the result of surgery. So going back to do more surgery really doesn't end up helping anyone. In the past, we had little tiny clips that we used for bleeding vessels. They weren't really designed to really close the full thickness of the GI lumen. So we've got new tools for that now. There have been a couple of series to show 60 to 80% success with this. And so I'll show you a couple of examples. Well, here are some of the tools. So we talked about the uncovered stent. This is what we will use for some of our luminal obstructions. And the idea here is that radial force and tumor ingrowth keeps it from sliding. And this is really for malignancy. Now the covered stent, you can see there's like a nice shiny covering on here. Now there's a silicone covering. The radial force is what holds it in place. So the intention was growing in, but now that it's got this covering and nothing grows in, it means you can remove it. So in a non-FDA approved fashion, we've used it for more benign causes. And so benign strictures, leaks, and fistulas. And the idea is if you've got a patient, let's say with like an esophageal surgery or maybe a sleeve gastrectomy, and they have a leak there, you can put the stent across the leak. And the idea is you're going to exclude the leak. You're going to divert GI contents away. And so now the leak dries up. Once the leak dries up, it tends to close. It keeps leaks open as ongoing flow. And then the stent itself kind of forms a scaffold for granulation tissue to form around there. The other tool here is talk about a lot is called the bear claw, which looks like one of these, old bear traps in like a Yogi the Bear cartoon. And the idea is it snaps shut. It's a big jaw that we put on the tip of the scope, and it literally snaps shut and actually closes the full thickness of the lumen. It actually grabs the deep muscle and actually does a really nice closure. So here's a perforation here, and here we actually can suction in a piece of momentum into that little hole and actually clamp the whole thing down. So here's a patient, this is from maybe 2 years ago. They had a sleeve gastrectomy here, and they came in with pain and fever, and you can see an esophagram or upper GI series. Here's the esophagus, and here is the sleeve, what's left of the stomach, and there's that leak. Contrast should not be extravasating out. You can see it again there. And so then with the endoscope, we actually can see pus in the lumen itself. And so there's a little bit of a defect. We suction, we see pus. And now here is where we place that bear claw, and that clamps it shut. And then it's in a belt and suspenders approach, and we cover the whole thing with the stent. And that really, again, excludes all GI contents, saliva, any bile refluxing back away. And then when we come back 6 weeks later, here's the esophagram. We shot contrast after that stent and bear claw, and you can see there's no more extravasation. And then now, a couple months later, we've taken the stent out. You can see that there's no more extravasation, and this patient did very well. Surgeons happy to call us for this because one, they don't want to go back to the OR. It looks bad for them. But two, going back to the OR doesn't really help anything because it's a scarred up area. It's already a complication. Here's a patient who had a iatrogenic perforation of the esophagus at another hospital during an ERCP. They had a thoracotomy over there. They tried to repair the perforation, but they still had a leak, and they got transferred here to repair. And so we went down. You can see here's the esophagram, and here's this leak going into the right chest, and you can actually see contrast down into the right pleural space over here. When we go with the scope, you can actually see sutures in the failed attempt at closure, and you can see there's pretty much a defect here. So we put a long stent in, and we shot contrast. There's no more leak. We come back about 8 weeks later, and it's a little like nodular granulation tissue, certainly very different from this. And when we shoot contrast in there, the leak is fully resolved. This is a patient from last month. They were at the VA. They had a gastric ulcer that perforated. They went to the OR and tried to close it, and closure is usually very successful. This patient had a lot of comorbid conditions, and when they were still leaking, they had drains in place, and they're still seeing bile pouring out. They called us. And so over here, this is the scope coming through. This is the pylorus over here, and that's just fine. And as we back our scope up, on the left side here, this is actually the perforated ulcer. You can see that opening is actually even bigger than the pylorus. And so deep in there is sort of what I call scary space. So what we'll do is we place a wire to sort of demarcate the pylorus so we don't close the pylorus, because that does not make you any friends. There's a plastic cap on the scope. You can actually see the teeth from that bear claw that we talked about. There's these teeth on the side here. So what we try to do is center ourselves over that perforation. And the idea is we're actually going to suck in the walls of that perforation. And as we do that, you can see the hole right there in the middle. We're centered very nicely. We're going to suction all of that in. And we throw this clip down. You can see the metal edges of the clip here. There's metal edges there. And then we actually injected contrast and dilute methylene blue. They had a drain in place. So if they were still leaking, we were going to see that blue dye come out into their drains, and it totally dried up, and the patient did fine. And no further surgery, leak healed, and the patient did well. There's a number of different series. The hard part about studying these is each of these patients, it's such a heterogeneous problem. because every patient's got different comorbid conditions. That's why they leak sometimes, and different surgeries. There's been a lot of case series, including one from our own institution here, about an 80% success rate in closing leaks and perforations and things like that. Generally, you keep stents and clips in for a few weeks at a time. Nobody really knows, because we can do suturing, we can do clips, we can do lots of things. No one really knows what is the best combination, but we have enough tools in our tool belt that we can sort of customize it to each patient. So this generally works very well. Another category, which I know these patients have been woefully parked on your respective services for very long periods of time, is the management of necrotizing pancreatitis. This is something that was never really probably taught to any of us in medical school, because in medical school, these patients went to surgical services. Certainly wasn't taught on your medicine rotations and medicine residency. Because up until about 5 years ago, all of these patients went to surgical services. And now with a better understanding of the disease and an advancement in technology, we're actually bringing them over onto the medical side, and with far better outcomes. When we have a combined endo and surgical conference on Fridays. They are happy not to touch these patients. I've never seen surgeons so happy to not touch a disease. But and I'll show you why. So with pancreatitis, most of the pancreatitis we see is what I call interstitial pancreatitis, or what we call. That's about 80 to 90%. 10 to 20% is necrotizing pancreatitis, where parts of the pancreas actually die. When parts of the pancreas die, now the mortality rate is jumped up dramatically from a usual couple of percent to now up to 30 to 40% mortality. And the historical precedent was those patients went to SICUs and got operated upon. And this is what we were looking at. So this is a patient with a pseudocyst. Now, a pseudocyst is a late development, some 3, 4, 5 weeks after you get acute pancreatitis. Early on, you get acute fluid collections, which is just sort of a ball of inflammatory fluid, but eventually develops this sort of fibrotic wall. You can see there's this wall around this collection here and another wall around here. Here's the pancreas right behind. And here, the contents here are fluid. So a pseudocyst means you must just have fluid in the cyst. It's a blister. If you burnt your hand before, a pseudocyst is just a blister. It's a wall of just inflammatory fluid. Now, this is called walled-off necrosis, which I personally hate this term, but it's a WAN, as it might be. And so early on, it's called an acute necrotic collection. You've got that piece of dead pancreas, and you've got this dead inflammatory ball. And as that wall, it's a little bit different. Here, it's very homogeneous. And here, you can see some different densities. Different density there. I don't know if it projects, but you can see various different densities in here. And what that is that's actually debris. Right? Now you've got dead tissue, and that dead tissue forms chunks of debris. And so it's heterogeneous. Some are much more heterogeneous than others. Now, you don't always have to intervene in these. Actually, very often you don't have to intervene. Only time we go after it is if they get infected. And that's pretty obvious. Early on, fevers and pancreatitis is just SIRS and inflammatory. But once you get beyond week 2 and 3, now you're talking about infection-related issues. Patients get obstructed when these things are huge and get mass effect. People get recurrent pancreatitis as they sit on the pancreas and cause disruption to the duct, biliary obstruction, and sometimes pain. In necrotizing pancreatitis, so the big reasons to go after these collections is that if you have suspected infected necrosis, and I'll show you a CAT scan with that, sometimes patients, they're just persistently unwell is the technical term, and they just means they just kind of got this smoldering low-grade infectious process and persistent organ failure. Some people get early organ failure with pancreatitis, but it should get better. If it persists, it might suggest an ongoing infection. So infected pancreatic necrosis occurs usually 2 weeks out. And so fevers at that point, persistent failure on the scan. So now this is an infected area of necrosis. You can see an air fluid level. You can see little air bubbles in the middle of this collection. Here's another one. This literally looks like the colon, like this stool looks like this. And that's just air intermixed with solid debris. These are the patients that used to go to surgery. So there have been a couple of really impressive randomized trials to address the techniques, and this is why I think our approach has changed. Let me explain this one approach here. This is called VARD, Video Assisted Retroperitoneal Debridement. So they're the classical approach for surgery, big laparotomy, open abdomen. Like they're so swollen you can't close them up, and they mobilize the organs and they literally go in and scoop out the dead tissue. Oftentimes it takes a couple of procedures to get it all out, but they're so sick you usually can't close them back up again. And so that's why they're in the SICU with open abdomens, and it's a disaster. The minimally invasive surgical approach is called a VARD. So this is, the retroperitoneal space. Here's the stomach. Here's the pancreas, and this brown area is an area of pancreatic necrosis. IR can place a percutaneous drain laterally right into that area. So you can imagine they would go like this, right here. And then a surgeon can actually use that drain as a guide to actually enter the retroperitoneum directly. And so they can do a minimally invasive approach with cameras and literally put a camera like a laparoscope through here and use tools to debride this out. So there is the Dutch pancreatitis group. They basically have taken the entire Netherlands and put them in a huge countrywide study. And they just do all these, you literally call 1-800-pancreatitis and you just get thrown into these big centers and they get transferred around. And so these super sick patients get randomized to phenomenal studies. So they get randomized to one of two approaches. One is a step-up approach. Necrotizing pancreatitis had an indication for drainage. In that group, they got drains like I just showed you. And if they needed a VARD, they went and had that done. But drains alone were sufficient in many. 60% needed a VARD and 33% needed a little more surgery. Open necrosectomy, again, they had the right indications. They got randomized to the open group. They got a laparotomy, and 42% needed more procedures. Major complications or death, this is like organ failure or death. This is a horribly morbid selection of patients. 70% of the open group died, 40% in the VARD group died. And a huge, obviously, difference in p-value. So that kind of took us away from open necrosectomy. This is why surgeons don't want these patients. It's a disaster. So some of the endoscopic approaches, this is a pseudocyst. This is that fluid collection we talked about, that blister. They had an infected pseudocyst. We put a needle inside. This is through the stomach wall. We're making our own fistula or a hole through the stomach wall. We're dilating a tract in that wall. And you'll literally see pus pouring out of this infected collection. And this is dramatic, and this is not unusual. And now you can see sort of a cave, heading into that cavity. We'll place stents in there, and this is a simple infected pseudocyst. So there's no solid debris. 4 to 6 weeks later, we come back and they're done. And the stents come out, the cavity closes, and they do very, very well. This is walled-off necrosis. You can see on ultrasound, we can see this debris in here. Simple fluid looks like this, very black. You can already see debris in here. So again, we're going to access this with a needle, the special stent that we have to do this. That needle has gone into the collection. You can see the stent opening up on the inside there. And as we kind of deploy, you'll see this is the other side of the stent. It looks like a butterfly. So again, some of this infected fluid pouring out. And now we can actually take a scope and enter the cavity now. Now that you've got this railroad track to go in, you can go in. You can see in here, this looks like stool. This is dead tissue. This is the retroperitoneal space. This is all and we're just literally taking tools and just pulling stuff out. This is a laborious, painful process. And this is literally just dead pancreas. And you will pull out piece after piece after piece out of this. This is what the surgeons used to do. And so you can see we're literally pulling out a big chunk of dead pancreas out of there. And sometimes you're literally like, this is a cast of a dead pancreas that one of us pulled out. You can see here now, and I know I've become a proceduralist when I look at a picture that looks like this, which I think this picture right after this of the cavity, I think it still looks horrible, but it actually looks pretty good. And like when surgeons are like, oh, it looks great, I'm like, are you kidding? It looks horrible. But this actually looks really good. The reason I say that is there's healthy granulation tissue here. There's no more black dead tissue, and so there's no more infected stuff. Sometimes we'll peel off this infected stuff and pus will flow out from another pocket from behind there. And so it's literally like you're just spelunking down there and you're just pulling out stuff, finding things. And this is what we call necrosectomy. So anytime you see these patients going for necrosectomy after necrosectomy, this is what we're doing. 2 hours at a time, 3 hours at a time, sometimes twice a week. To get rid of that stuff. So does it work? The previous trial told us that the minimally invasive approach was better than the endoscopic. This is the surgical step-up group. Again, same thing, putting in drains, going for VARD, and then some of them needing surgery, similar to the prior study. The other 51 patients got randomized to endoscopy. They went for that stent placement first, just to drain alone, and then 60% needed a necrosectomy. 40% of those needed repeated necrosectomies, which is certainly our experience. Major complication or death, still very morbid, 40%. Okay, so at any time we start with these patients, we tell them there is a pretty high chance you might die. This is an incredibly morbid disease. Fistulas, when you have all these percutaneous drains and they finally heal, they end up with these fistulous tracts of pancreatic fistulas, where pancreatic enzymes leak out their abdomen. In the endoscopic group, there's no fistulas. Look at the length of stay difference. Those 7 weeks depend on your service. That's average. Okay, and then the surgical group's even longer. These are 2 or 3 months in the SICU typically, and all of those were statistically significant, except for that. So does it work? This is a patient some of you may have taken care of. We take care of John Day when he was here. He was a 24-year-old upstate, had an ERCP for unclear reasons, got bad pancreatitis, which turned into necrotizing pancreatitis, got transferred here, was in the unit, was persistently febrile every day to 102, was on dialysis, and was a mess. Like, literally was drenching in sweat for 2 weeks. We went at this. This is his original scan. This is all this inflammatory phlegmonous ball of crap. Here's his stomach. This is all where his pancreas is supposed to be, and there's just no organs there. It's just inflammatory tissue. 6 weeks, so 3 weeks after he got here, we got him off dialysis. He stopped spiking temps, and we were just twice a week in there. And now you can see now all of that inflammatory stuff is gone. It's all gone. The cavities are gone. He's got a couple of stents in there for final drainage, but all of that inflammatory ball is resolved. Left the hospital after 6 weeks, is living a normal life. And he was nearly dead when he got here. So it takes a long time, but they do really, really well. So it does work, and this is why you're seeing these patients on medical services now. So major centers across the country, think of the major players here in New York the same way. There's 1 or 2 big centers in each city that are starting to do these. But I think it's changed the face of this disease, and it really does work. It just takes quite a long time.
So did that patient have efficiency?
He turned out not to. The problem is 1/3 of them are at risk for recurrent pancreatitis, only because the pancreas got so beaten up, it's at risk. Some people end up with exocrine insufficiency and diabetes. He did pretty well. Fortunately, he came into it reasonably healthy. But some of these older patients, a little marginal. We had a long run of these in the spring. Pancreatitis has been a little quiet this fall, but it'll change. The last quick category is just endoscopic drainage. This is the stent we used for pseudocyst. It's what it was designed for. It's a butterfly stent. It's very short, but it's got a big lumen you can enter into. Here's a little schema of it. We can use the scope, and here's the gallbladder next to the duodenum. We can actually poke a needle into the gallbladder now, inject some contrast, and put a wire through there. And then the final part of this is placing this stent. So think of this as an alternative to a perc cholecystostomy tube. You're putting the stent inside of here, and now you've connected this gallbladder, which is infected, to something, to the lumen, rather than doing it externally. So here is a patient, comorbids, hypoxemic respiratory failure, acalculous cholecystitis. On endoscopic ultrasound, here's his infected gallbladder. We're going to deploy the stent real quickly. And then you'll see on the endoscopic view in just a moment here, as we back up, this stent's going to spring open. Now you can just see this nasty, infected, sludgy crap literally pouring out of his gallbladder. And as we keep going and we dilate this up, I mean, the stuff that's in there is just basically mud. And he recovered from his sepsis, not from the rest of these issues eventually, I'm sure. But now you can see this infected, sludgy stuff coming out. This has worked acutely. It's worked great. No long-term complications so far. The question of can we replace perc cholecystostomy tubes? There's some cohorts that seem like it's okay, but there's a trial that's going to come. Another lady, similarly, she had a pelvic abscess, and you can see here once we placed it, just this pus pouring out of her pelvic abscess. She was an ultrasound tech from another hospital, and she would just scan herself periodically to check in her abscess. It was kind of weird. this is coming. We've already started to do this. Gastrojejunostomies. Here's the stomach. Here's the jejunum. Here's that duodenal obstruction we talked about. We can use that stent and connect the stomach to the jejunum and actually do a surgical bypass on patients. Last slide. So we've got just a really expanding arsenal of devices and techniques to tackle a lot of conditions. Luminal obstruction is readily palliated. Really restores normal GI tract function. Leaks, perforations, and fistulas can be closed with endoscopic techniques. It's about patient selection, making sure infections are drained, making sure other issues are managed, they're getting nutrition. Necrotic collections for pancreatitis are now preferentially managed with endoscopic procedures alone. We work in teams on this. We work with IR. We work with our surgeons. Some of our surgeons here are really adept at understanding VARD versus endoscopic things. Abscesses and even gallbladders can be drained. We need to figure out the right window and the right patient. And the last thing is anything is possible, just ask. We're always up for being creative and trying new things. Our fellows have now stopped just saying no to things and just come and ask us first. If we can get there, and we're always willing to try something new. So just keep that in mind. Thank you. Back there first.
Yeah, so this is, thank you so much for the lecture. And it's probably more like, as a clinician, how do I tap IR versus GI versus surgery? Sometimes it gets confusing, and sometimes when I consult with one service, the service will say, okay, consult IR, and I'm like, it's very confusing.
A lot of it's going to be anatomy. So for us to be able to do something, we have to be able to get there. So it's got to be next to the rectum or next to the stomach or the duodenum. Sometimes there are things in the middle of the abdomen or near small bowel, and we can't do much. I don't even expect general GI to even know that. That's a question that an interventionalist is going to have to answer. Because we look at our own scans to try to figure out, can we get there and in what fashion? Sometimes IR is the right way to go. We get a little leery about it. They're very good, but drains are hard. I mean, you see our patients don't love these drains are a miserable mess. So it depends. Many times we'll even say go to IR if the anatomy doesn't make sense or if the disease process doesn't make sense. So discrete abscesses are pretty straightforward. Gallbladders in patients that maybe a Pert Coley tube isn't the best choice is pretty straightforward. Things around the stomach, things around the rectum, those are really ripe for GI intervention. And those are really the best places for us to intervene. Yeah. So that's a big thing. That's what causes the infection in pancreatitis. So it's basically translocation of gut flora across into some of these infected spaces. So pancreatitis is initially sterile. And then eventually over time, as the mucosal barrier breaks down in the GI tract from nutrition, chronic inflammation, and so on, then you get some translocation of that gut flora into those spaces which are supposed to be sterile. So it's a late phenomenon, 2 weeks, 3 weeks later. That's why early pancreatitis is always very sterile, because the retroperitoneum is sterile. But eventually, that's all of the infections that happen, they're all gram-negatives. They're all gut flora.
Just piggybacking off Noel's question about when to call GI versus surgery, is there the bear claw thing, how big a lesion can that be?
Usually about like 15 to 20 millimeters.
Okay, so if it's bigger than that, probably it needs it.
Right. And if it's bigger than that, it's hopefully not on your surface.
Oh, yeah. It might be.
But yes, that's true. What am I saying? So, but yeah. And if it's sort of patients already been operated on before, sometimes it's too fibrotic and surgeons don't, even for any of us, it's very hard to close those things. But, smaller things, 15, 20 millimeters, that's about the top end of what we can generally do.
What's the complication maybe of the bear claw? Does it ever cause major bleeding or perf in and of itself?
Generally not. In fact, we've even used it for severe bleeding because you get such a deep grab of a blood vessel. So sometimes if we're totally in a bind, they've called us to put bear claws on vessels, and it's worked very well. Generally, no complications at all. You just have to be careful. It's a big device, so it's hard to get it through someone's esophagus. And if you're not careful, you can close off lumens. And that would be, as we talked about, bad. But generally, it's a very safe thing to do. The key is just, can you get it there? But we've had patients who were post-op and colon leaks and fistulas, things like that, and it works. It works great.
From a thousand care standpoint, if a ventral tube is clogged or for peg feeding is clogged, what can we do at the bedside for the polyene guys?
Coca-Cola. Have you tried it? It works great. It's disturbing. I mean, patients will call and like, no, flush some Coke in there, and it actually works disturbingly well. And so, but beyond that, if it doesn't go, then we'll have to just take a brush and try to do something to open it up. That's true for any feeding tube. Sister, drink Coke. Exactly. Thank you guys. Feel free to email, call us anytime. We're always happy to look at stuff, so never hesitate.
Thank you.